This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome to the Neurology Journal podcast. I'm Jessica Ailani, Director of the Georgetown Headache Center and Professor of Clinical Neurology at MedStar Georgetown University Hospital in the Washington, D.C. area. In this session, we will be discussing the article Characterizing Prodrome, Premonitory Phase in Migraine, Results from the Prodrome Trial Screening Period. We have with us one of the authors, Richard Lipton, Director of the Montefiore Headache Center and Professor of Neurology, Psychiatry, and Epidemiology at the Albert Einstein College of Medicine. As a neurologist and headache specialist, I often find the bulk of my day spent discussing head pain and disability that it brings to my patients. This is often done in a dark, quiet room, as I know the associated symptoms of migraine are ever present for those with high-frequency attacks. Migraine, though, is not only about head pain and associated symptoms, the part of the attack known as the headache phase. While clinicians will often focus on this part of a migraine attack, migraine is so much more, and all phases of migraine are disabling to patients. If a patient can identify their attack at the earliest onset, at prodrome, they may be able to start treatment and reduce disability. But how do we have these conversations with our patients? Richard, welcome. I'm really looking forward to our discussion on prodrome today.
Great to be here. Thanks so much for having me.
So before we discuss your study, can you tell our audience a little bit more about prodrome?
The prodrome or premonitory phase of migraine is the first phase of the migraine attack. It consists of warning symptoms that precede the onset of aura or the onset of headache. These symptoms let the patient know a migraine attack may be coming. In a recent meta-analysis, it was reported that in population studies, a full 2/3 of people living with migraine have prodromes. And during the prodrome, there are neuroimaging changes in the hypothalamus, midbrain, and limbic system. Prior studies have shown that some people can predict the onset of migraine before head pain begins. And for many years, we've wondered if treating during the prodrome could actually prevent the onset of head pain.
So Richard, you and I have had this conversation before, and I know we've had a very enlightening discussion about when does migraine actually start? Do you think it starts at prodrome, or do you think it starts after prodrome?
I think the prodrome truly is the first phase of the migraine attack, in many ways similar to the aura being the first phase of an attack of epilepsy. And as we'll discuss, the most common symptoms of the prodrome phase, such as neck pain, fatigue, light or sound sensitivity, occur in people without migraine, and they also occur in people with migraine outside the context of an impending migraine attack. So just because someone with migraine has a feeling that is a warning symptom in some people, it may not be a warning symptom in them. But when a person with migraine has their characteristic warning symptoms and they think an attack is coming, in the group that's good at predicting attacks, they're usually right. And imaging studies show us that brain changes begin before headache onset.
Other things we've discussed is the idea that, and our field in headache discusses this often, is if prodrome is onset of migraine, and prodrome symptoms can include things like neck pain and sometimes even things like food cravings, many of our ideas of triggers like light sensitivity, so patients who come in and think that bright lights are a trigger of migraine, might actually be prodrome and the first warning of migraine itself. So I find that this particular set of studies that have been done on prodrome really have advanced the field tremendously. So tell me, Richard, tell me a little bit more about the study itself, the prodrome study.
Prodrome was a multi-center, randomized, double-blind, placebo-controlled crossover trial that enrolled adults who had 2 to 8 migraine attacks per month, characterized by moderate or severe pain. In the study, eligible participants treated 2 qualifying prodrome events, and a prodrome event in this study was a set of prodromal symptoms that the participant was confident would be followed by a headache onset over the next 1 to 6 hours. So following such an event, participants were randomized to one of 2 sequences. First, they treated with placebo, and the next qualifying event, they treated with ubrogepant 100 milligrams, or in sequence 2, they treated the first attack with ubrogepant 100 and the next one with placebo. And, this was a typical crossover design. So the trial included a 60-day screening period designed to test the idea that people could actually predict their headache onsets. And participants used an electronic diary to report their prodrome symptoms and then went on with the electronic diary timestamp to report whether a headache actually occurred. This analysis evaluated common prodrome symptoms and their severity, time from prodrome onset to headache onset, and the proportion of participants who were successfully able to predict their headache 75% of the time or more. There have been 3 papers from the study. The first one by Dave Dodick was published in Lancet and presents the primary results of the study. I led a paper looking at patient-reported outcomes published in Neurology, and then Todd Schwett was the first author on the paper we're discussing today, which appeared in Neurology Clinical Practice last year.
So what did you find in this particular paper looking at the characteristics of prodrome?
So we enrolled more than 900 people in the electronic diary study. We recorded their warning symptoms and headache. We recorded a total of almost 5,000 warning symptoms. And the first thing we found was that the common prodromal symptoms were sensitivity to light, identified in nearly 60%, fatigue identified in about half, neck pain identified in about 40%, sensitivity to sound in about a third, and cognitive difficulties, either difficulty thinking or concentrating, also in about a third of patients, and then dizziness. Of all the prodromal symptoms, 81% were followed by headache from 1 to 6 hours after the initial reporting of the symptoms. And overall, more than 3/4 of participants who identified qualifying prodrome events found that they were followed by headache more than 75% of the time. So sort of the bottom line is this teaches us what symptoms are most common in prodrome, and also that in people who were selected for being able to predict their headaches, 75% of people were right 75% of the time or more. And of course, this backdrop of being able to identify a group of good predictors not only helps us characterize the prodrome, but it's essential to being able to treat during the prodrome.
I think the emphasis here is not only good predictors are good predictors, trust your patients when they tell you they kind of get a sense of what's going to happen, but the idea of being able to identify the top 5 prodrome symptoms, to me as a clinician in headache, this was really key. The findings from this study, that was a big takeaway. That, and of course, being able to have a treatment to use in those that can identify their prodrome reliably. The reason this is important for anyone who's really understood or has been following any of the research on prodrome for decades now, we have a screener of 30 plus different symptoms. And when you're in clinical practice and you're rushing through and you're trying to talk about migraine as a disease and you're going through everything with your patients, it is really hard to run a screener of 30 something symptoms. And you're doing lots of screeners for these patients. So they get screener fatigue at some point. But to be able to ask them about 3 or 4 top items very quickly, my ability to really explain Prodrome to patients after these findings over the last 2-3 years, because we had them in abstract form, we've kind of known about them in the field for the last 2 years since this data has first been presented at the AAN, it's been tremendous. So we've been able to improve quality of life from these findings very quickly. And I mean, to me, that's been the most exciting, but also a little surprising. Were you surprised by any of the top 5 Prodrome findings? Were you thinking you were going to see something else come out of the data?
First, let me say in practice, if you give people a checklist of 30 symptoms, you're at very high risk of getting false positive reporting. So the approach I take is to say to people, do you get a warning that lets you know a headache is coming before the pain begins? And most people say yes to that question. And then I say, well, what are your experiences that let you know a headache is coming? And then if people say no, then I screen them for the most common symptoms. And I think that reduces false positive reporting. I was surprised that so many people were such good predictors of headache onset, although there was a prior study by Giffen, actually also published in Neurology, that showed people could predict impending headache with a similar level of accuracy. I was not surprised, but I was very interested in the observation cognitive symptoms, difficulty thinking or concentrating, were common and robust predictors. So in our work trying to develop better patient-reported outcomes for use in migraine trials, we've done a boatload of qualitative work. And in that qualitative work, we found that cognitive symptoms were very common in the prodrome, but I was fascinated by the observation that these cognitive symptoms, when they occur, are actually predictive of impending attacks.
So did you find that there were any limitations to the study?
Well, so a big limitation is that the study enrolled people who thought they could predict headache onset from their warning symptoms. And then we demonstrated in those people who believed they were good predictors that they could, in fact, accurately predict the onset of headache over a 6-hour window. So findings of this study might not be generalizable to people who are not good at predicting migraine attacks, and we don't really know what proportion of people with migraine would do this well if we subjected them to this sort of design. And again, if you make a false positive prediction, if a patient says, I'm going to get a headache and they were wrong, if they take active drug or placebo, the headache's not going to come because they're treating a false positive prediction. So the risk of some false positive predictions is another thing to think about, not so much in any risk of using a GPANT, but just more from the cost of treating attacks unnecessarily.
So how would you recommend to use the findings of this study? And do you feel like it's changed how you've practiced seeing patients in the office?
I think the concrete application of the results of the study is much along the lines of the comments that we've made already, asking people about warning symptoms, and if they say no, asking them about the most common warning symptoms. But in addition, there's been a trend over many years of using acute treatments early. So in the triptan era, we had patients wait to treat migraine until their pain was moderate or severe. But we learned that treating early in the attack while pain was still mild produced much higher rates of freedom from pain. And we know that's true for triptans, for NSAIDs. We know it's true for at least one gepant, ubrogepant as well. And in the triptan era, there were some small studies trying to see if triptans would work during the prodrome, and broadly speaking, they didn't. Andy Ahn gave us a clue as to why they don't work, and the reason is that the 5-HT1D receptors that triptans bind to sit on synaptic vesicles inside trigeminal nerve terminals, and after headache begins, those receptors are externalized and become available. Of course, that's not true for gepants, which bind and target CGRP. In the primary prodrome report, when people treated with ubrogepant, they did not get a moderate or severe headache over 24 hours in nearly half of cases, where 29% of people who treated with placebo got that level of effect. So there's good evidence that treating with at least this one gepant works during the prodrome. So the effects it's had on me is that I'm more attentive to prodrome, and my notion of what it means to treat early has shifted from treating while pain is mild to treating in the prodromal phase when people can predict impending attacks.
Thank you, Richard. I really appreciate you going through all the data for Prodrome. I know that this data has really made a huge impact in my clinical practice, which then means it's made a huge impact to all those patients out there. Do you have any last words for our audience?
Effective acute treatment is important for many reasons. I mean, first of all, everyone with migraine needs acute treatment, although not everyone with migraine even needs a prescription drug. The obvious reason we give acute treatments is to relieve pain and restore function, but a less obvious reason is that migraine is a sometimes progressive disease. And if you're using an acute treatment that doesn't work, large epidemiologic studies show that ineffective acute treatment is itself a risk factor for progression. One of the leading hypotheses for this observation is that pain begets pain through the mechanism of central sensitization. Now, if you wait for moderate or severe pain to treat, the patient has the pain that precedes the onset of headache, and the patient has ongoing pain while they wait for medication to kick in. So one huge advantage of treating during the prodrome is that when it's successful, it fully prevents the pain, and that might not only reduce suffering and improve ability to function today, but there's a chance, and this hasn't been studied, that it'll reduce the risk of progression as well.
Outstanding point. Thank you so much for joining us today, and thank you so much for listening. If you want to learn more about Prodrome, take a look at this study, Characterizing Prodrome and Migraine, Results from the Prodrome Trial Screening Period in Neurology. You can also take a look at either of the other two articles available in Neurology or The Lancet.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.